Sertraline. This is Doctor of Mind, psychiatrist. Here's some thoughts on sertraline. I love it. If you had to take an SSRI, sertraline, it was the best in its day. See, Prozac was too strong. 80 of Prozac. And Paxil is too weak. What do you mean? It makes you tired and you gotta take it before bed? Hence Zoloft or sertraline's in the middle. Now, remember, this is before citalopram, escitalopram came out. So Zoloft was perfect because it didn't have the connotation of Prozac, which was way too activating, or Paxil, which is sort of weird for an SSRI if you think about it. It kind of relaxes and makes people tired. It's the only SSRI you could actually take before bed. Weird. And Zoloft or sertraline's good because I like the sad heart study. They studied it in patients who've had heart disease and it's safe. That was great compared to things like tricyclics, which are dangerous if you've had heart disease. Now, of course, sertraline has all the negative connotations and aspects of all SSRIs: sexual dysfunction, headache, anxiety, insomnia, sweating, teeth grinding, restless leg, you name it. But it's better than Prozac for a lot of people and stronger than Paxil or paroxetine. So remember, it was fluoxetine was the strongest. Sertraline is in the middle. Paroxetine was the mildest. Now, as far as potency goes, then Celexa or citalopram came out, which is very, very mild. It's even milder than paroxetine. And then escitalopram, which I think's strong. Like 20 of Lexapro can make you manic. There's a big difference between 10 and 20. So escitalopram 20 is stronger than Prozac in my view. So here you have the potency of SSRIs, just totally based on prescribing it for years. Lexapro, Prozac, Zoloft, Paxil, Celexa. Now, why is that important? Say you have an actively psychotic patient on antipsychotics and they get depressed, which is very likely. I wouldn't want to use very strong antidepressant, for example. I like citalopram or Celexa in psychotic depressed patients. Whereas I would avoid 20 of escitalopram in the actively psychotic depressed patient personally. So there you go. That's a little thing about sertraline, its relation to other SSRIs. It comes in 25, 50, 100. Max is 200. Don't do 300. What the heck? People can go crazy with the dose. That's not safe. What happens with too much sertraline or any SSRI? Serotonin syndrome. Anxiety, sweating, agitation, tremors, seizures, coma, and death. So you don't want to do extremely high doses of sertraline. You could switch to a more potent one if maximum dose isn't working anymore, like fluoxetine or escitalopram. Or, quite frankly, you can just move up to an SNRI, a dual agent, like duloxetine, venlafaxine, or desvenlafaxine. If you try Wellbutrin, a pure NRI, it may not be strong enough, but it could be important as an option. You can also add bupropion to sertraline. That's cool. You can't add tricyclics to sertraline, in my view. There's less drug-drug interactions than with fluoxetine, and for sure paroxetine. Oh my God, the 2D6 with the paroxetine's crazy. And by the way, check the new antidepressants 2D6. Whoa. Zoloft is good in that sense, sertraline, because there's less drug interactions. You're supposed to take it in the morning. You don't take it at night. You generally don't take any SSRI before bed, except maybe Paxil. Or if they happen to make you tired in maybe 10% of the cases. I'm sorry, I'm on call again tonight. There's already been 2 admissions. There's a blizzard, and if there's restraints, it's going to be hard to get in within an hour. But this time, instead of them saying, why don't you take a cab? Yeah, right. I have a colleague who's an emergency backup for middle of the night restraints in a blizzard. This time I was smart about it. The antidote to too much sertraline is Benadryl. Isn't that cool? Sertraline in the morning or Benadryl at night, or diphenhydramine for insomnia. That's common. Trazodone at night also mixes good with sertraline. You wouldn't think so, but it does. Okay. Lithium, Depakote, Tegretol, and Lamictal all mix okay with sertraline. Most of your atypical antipsychotics do too. I love sertraline and Risperdal, for example. What you don't mix with sertraline is another SSRI, duh. Or an SNRI, I don't like that. And really stimulants, although you see that. Okay, it's a nice introduction to sertraline. Generally 100 usually works good. I like the higher dose for OCD and eating disorders. The lower dose for depression, anxiety. And a gentle introduction is important. If you're switching from a fluoxetine with a long half-life to sertraline, you could get side effects because the fluoxetine's still in the body. Whereas when you switch from paroxetine to sertraline, the half-life goes longer, so there's no withdrawal from the paroxetine, so that's easy to just switch. So it's important to get instructions from the doctor on how to switch it, and be careful. A bad reaction, I would say, to sertraline is if it makes you more depressed, oops, suicidal, agitated. That's like an adverse drug reaction. So please talk to your doctor. I've also, in rare cases, used sertraline to get off of side effects. In other words, some of the SNRIs are so nastily potent, you have to use an SSRI just to get off the SNRI. One of the best things I've done with sertraline for years is double it premenstrually. That is so wild. Talk to your doctor about that. Good night.